So today our class is approach to hemolytic anemia. So basically what is hemolytic anemia? It is due to destruction of the red blood cell. Those anemias which result from an increase in RBC destruction coupled with increased erythropoiesis. Classification: congenital and acquired. So it is of two types, hereditary and acquired. Hereditary is, it is of two types, intracorpuscular and extracorpuscular. Intracorpuscular means blood cell RBC destruction occur inside the vessels, blood vessels. And extracorpuscular means RBC destruction occur outside the vessels. So hereditary, hemoglobinopathies, enzymeopathies, membrane cytoskeletal defect, and extracorpuscular familial hemolytic uremic syndrome. Acquired PNH, paroxysmal nocturnal hemoglobinuria. And in extracorpuscular, mechanical destruction, toxic agent, drug, infection, autoimmune. So intravascular is microangiopathic hemolytic anemia, transfusion, PNH, infection, snake bite. Extravascular, hemoglobinopathy, enzymeopathy, membrane defect, and autoimmune hemolytic anemia. So there is two main principles. One is to confirm that it is hemolysis, and two is to determine the etiology. Now, how to diagnose hemolytic anemia? New-onset clinical features: new-onset pallor or anemia, jaundice, splenomegaly, gallstone, dark color urine, leg ulcer. These are the as a whole clinical features of hemolytic anemia. And findings: general examination, jaundice, pallor, bossing of skull, physical finding, enlarged spleen, hemoglobin from normal to severely reduced, MCV usually increase, reticulocyte increase, bilirubin increase, LDH increase, haptoglobin reduced to absent. This is the hemolytic facies, also called Chipmunk Faces. It is seen in Thalassemia major, mainly seen in Thalassemia major. As a whole, it is hemolytic facies. Now, the hematologic finding: routine black film, polychromasia, reticulocyte will increase, bone marrow examination, erythroid hyperplasia. Why? Because at first bone marrow will try to compensate the anemia. That's why in bone marrow erythroid hyperplasia will occur because bone marrow is trying to compensate the anemia. Plasma or serum finding: bilirubin in case of both extravascular and intravascular, unconjugated bilirubin will increase, haptoglobin decrease or absent, plasma hemoglobin normal or increase, LDH variable. Urine bilirubin will present. These are the polychromatic cells. The key to the etiology of hemolytic anemia: history and peripheral blood film. Patient history: in the patient history, we have to inquire about the onset. Is it acute or chronic? Medication: drug precipitants like GCSPD, autoimmune hemolytic anemia, family history, concomitant medical illnesses, clinical presentation. Now it is a case number 1, a 3-year-old child, male child, present with pallor, jaundice, severe pain of long bones, fever, in CBC, anemia, reticulocytosis, increased WBC. Lab findings, LDL 600 and serum bilirubin 5 mg. So, what is your diagnosis? And these are the peripheral smear. You can see these cells. It is a case of sickle cell anemia. So, finding these are sickle cells, sickling. These are sickle cells is like sickle. Diagnosis, how to diagnose? Hemoglobin electrophoresis or HPLC. HbS value will more than 80%. In case of HbS trait, the HbS value will between 22 to 40%. In case of HbS disease, it is HbS value will be 70 to 90% or sometimes maybe 100%. Here it is more than 80%. So it is a case of sickle cell anemia. Sickling test positive. So mutation, it is the pathogenesis, mutation in beta globin 6 chain glutamic acid to valine. And for that, what is occurring? Veno-occlusion, microinfarction, ischemic pains, autoinfarction, and due to decreased RBC survival, anemia, jaundice, gallstone, and leg ulcers. These are the clinical features: painful crisis, hemolytic anemia, reticulocytosis, granulocytosis, vaso-occlusion, hand-foot syndrome, acute chest syndrome. These are the sickle cells. These are the sickle cells. It is a case of sickle cell thalassemia. There are a few types of sickle cell disease: sickle cell trait, sickle cell anemia, sickle cell beta thalassemia, sickle cell beta plus thalassemia, HBSC. Now, second is 6-year-old child present with severe pallor, jaundice, growth delay, abnormal facies, hepatosplenomegaly, history of recurrent blood transfusions, CBC hemoglobin 3 g/%, MCV 58, MCH 19. That means it is microcytic hypochromic because it is MCV is less than 80 and it is less than 28. So in peripheral smear, microcytic hypochromia with cardiac cell. So what is the diagnosis? These are the cardiac cell. Okay, why it is called cardiac? Because this is due to abnormal hemoglobin addition. It is a case of thalassemia. Okay, it is a case of thalassemia. So other test, hemoglobin electrophoresis, DNA analysis for mutations, alpha thalassemia and beta thalassemia. There are two types of thalassemia: alpha thalassemia and beta thalassemia. Beta thalassemia is of three types: major, intermedia, and minor. Mutation in the beta globin expression prevents splicing of mRNA. And in peripheral smear, we will find hypochromia and microcytic. That means microcytic hypochromic. Beta thalassemia major, severe homozygous, childhood growth delay, severe anemia, hepatosplenomegaly, recurrent transfusion, iron overload. In case of peripheral smear, severe microcytosis, cardiac cell. And hemoglobin electrophoresis or in HPLC, finding is HbF is 90 to 96%, more than 90%, HbF value. HbA2 will be normal, that means 3.5 to 5.5, slightly raised, but HbF will raise more. Now beta thalassemia intermedia. Similar stigmata-like measure, survive without recurrent blood transfusion, less severe than measure, and HbF value is 20 to 100%, and A2 is 3.5 to 5.5. Now beta thalassemia minor, profound microcytosis, target cell, minimal anemia, similar blood picture like iron deficiency anemia. Lab investigation MCV less than 75, hematocrit less than 30, and hemoglobin erythropoiesis 3.5 to 7.5. That means HbA2 value is more than 3.5. But here HbF is normal. In case of major, the F value is more than 80%, 80, 90 or 100 in case of major. In case of beta thalassemia minor, HbF will normal. But here problem lies with HbA2. Here HbA2 will be more than 3.5. Basically it is 4 to 9%. 4 to 9%. That is called beta thalassemia minor. Now alpha thalassemia. Alpha thalassemia we cannot diagnose in our HPLC. So alpha thalassemia diagnosed by genetic counseling, by genetic study. Normal thalassemia trait, HbH and Hb Bart or hydrospitalis. These are the types of alpha thalassemia. Now next is 45-year-old male came to OPD in a remote PSC with burning micturition, urine routine microscopy show numerous parcels, UTI diagnosed, and corticosteroid BD for 5 days prescribed. 1 week later, patient develops severe pallor, palpitation, jaundice. Lab finding increased LDH, serum bilirubin, retic count. Peripheral smears show irregular cells. These are the Heinz bodies. It is a case of GC deficiency. Now, what we will find in peripheral smear? Bike cell, Heinz bodies, and polychromasia. And GC level will increase, and fluorescent spot test positive if black spot fails to fluorescence in UV. Clinical features: acute hemolysis, drugs, infections associated with diabetic acidosis, facies, neurological jaundice, congenital non-spherocytic hemolytic anemia. Now, these are the risk factors of GC deficiency. Antimalarials, primaquine, dapsone, sulfonamide, sulfonylurea, dapsone, antibacterial, potrimostazole, malic acid, nitrofurantoin, antipyretic, acetylenic, and pyridium. These are the definitive risk factors for GC deficiency. Second is pyruvate kinase deficiency. It is an autosomal recessive disorder, deficient ATP production, chronic hemolytic anemia, clinical features hydrospitalis, neurological jaundice, compensated hemolytic anemia. What is compensated hemolytic anemia? When our bone marrow compensated the degree of anemia. That is called compensated hemolytic anemia. Investigations, peripheral smear, prickle cells. Prickle cells is contracted RBC with spicules and decrease enzyme activity. Now case number 4. 14-year-old female present with anemia, jaundice, right hypoalveolar pain. On examination, vital stable, pallor present, icterus present, splenomegaly present. USG, polyneurosis, lab elevated LDH, and serum bilirubin. These are the cells, peripheral vascular. It is hereditary spherocytosis. These are spherocytes, these cells. The differential diagnosis, hereditary spherocytosis, autoimmune hemolytic anemia, other diagnostic test, osmotic fragility, and Coombs test. Hereditary spherocytosis usually inherited as autosomal dominant disorder. Defect, deficiency of beta-spectrin or ankyrin, loss of membrane surface area, becomes more spherical, destruction in spleen. Clinical features: pallor, jaundice, megalomegaly, pigmented gallstone in 50% of cases. Clinical course may be complicated with crisis. One is called hemolytic crisis and another is called aplastic crisis. Investigations: test will confirm hemolysis in peripheral smear, spherocyte will present, osmotic fragility increased, and screen family members. Now, autoimmune hemolytic anemia. Result from RBC destruction due to RBC autoantibodies, that is IgG-NEA. Most commonly, it is idiopathic. Classification: warm and cold. Warm autoimmune hemolysis, antibody bind at 37 degrees Celsius, and cold autoimmune hemolysis, antibody bind at 4 degrees Celsius. Warm autoimmune hemolysis can occur at all age group. Female, more, in case of female it is more. 50% is idiopathic. Rest secondary cause. Secondary causes are lymphoid neoplasm, CLL, lymphoma, myeloma, solid tumors, lung, colon, kidney, ovary, thymoma, and drugs, alpha-methyl dopa, penicillin, and HIV. Investigation: hemolysis, MCV decrease. Peripheral smear, microspherocytosis. Confirmation: direct Coombs test or antiglobulin test. Now, cold hemolysis, cold autoimmune hemolysis. Usually IgM directed at the RBC. Infection, mycoplasma pneumoniae, infectious mononucleosis, neoplasms, Waldenstrom macroglobulinemia, lymphoma, CLL, Kaposi sarcoma, myeloma. Clinical features: elderly patient, exacerbation in the winter, cold, painful, and often blue finger, toes, ears, or nose. That is called acrocyanosis. Investigations: hemolysis, peripheral smear, microspherocytosis, direct antiglobulin test or Coombs test. Direct Coombs test will be positive. Now, next is 32-year-old presented full-day history of distension of abdomen and right hypoalveolar pain and has history of passage of dark color urine at night for weeks. On USG, hepatomegaly, gross ascites, hepatic vein thrombosis, and these are the lab findings. Hemoglobin 7, WBC 2200, platelet 80,000, LDL 600, and serum bilirubin 4 mg%. So, what is the diagnosis? It is a case of PNH, paroxysmal nocturnal hemoglobinuria. It is an acquired cause of chronic hemolytic anemia. Persistent intravascular hemolysis, pancytopenia, hemosideruria, increased LDH, bilirubin, risk of venous thrombosis. Clinical features: hemoglobinuria during night, polychromasia, and normoblast. These are the findings of peripheral vascular. Bone marrow, normoblastic hyperplasia. Different definitive diagnosis: flow cytometry, CD59, CD55, and Heinz acidified serum test. Now, next is 25-year-old male with RSD, severe MR done MVR. After 10 days, presented with pallor, palpitation, jaundice. CBC shows hemoglobin 7.5, hematocrit 22%, serum bilirubin 4.5, LDL 600, retic count 10%. It is a case of non-immune acquired hemolytic anemia. Number 1 is mechanical trauma. Mechanical heart valves, arterial graft cause shear stress damage, and next is marked hemoglobin urea. Red cell damage in capillaries of feet, and thermal injury burns. Next is microangiopathic hemolytic anemia. By passage of RBC through fibrin strands, deposit in small vessel, disruption of RBC. Other finding: leukocytosis, thrombocytopenia, hemoglobinuria, deranged RFT, PT-FFT prolonged. Now the acquired hemolysis, cause of acquired hemolysis. Infection, falciparum malaria. Intravascular hemolysis called black water fever. Clostridium perfringens septicemia. Chemical or drugs oxygen denaturation of hemoglobin. Example: dapsone, sulfosalazine, arsenic gas, copper, nitrates, and nitrobenzene. Peripheral blood smear, spherocyte is found in autoimmune hemolytic anemia and hereditary spherocytosis. Cystocytes with thrombocytopenia, familial HUS, PTP, or DIC. Without thrombocytopenia, heart valve hemolysis. Viscous cell in case of oxidative damage in GCPD. Sickle cell anemia, Heinz bodies found in alpha thalassemia and GCPD deficiency. Now the conclusion: hemolytic anemia can be recognized by clinical picture from history, from physical examination, and lab test and peripheral blood smear.